Ladies and gentlemen, I'll request OP to please join me here. He is the chairman for the next session. And we have the speaker, Dr. Kushagra Katariya, who needs no introduction to this audience. You have been seeing him since morning. He is a speaker par excellence, lot of contribution in the cardiac surgery, done more than 900 heart transplants in the Miami University, and a very eminent person. And his contribution is known all over the world. And I don't want to speak too much about him. I think, excuse me, get the oration. Okay. Now this is a very prestigious oration of Dr. APJ Abdul Kalam, and we are really privileged to bestow upon this oration to none other than Kushagra Katariya. I'll request Vijay Lakshmi, Dr. O.P. Yadav, and Dr. Isar. Dr. Isar, please come on the dash to bestow upon this oration medallion as well as scroll. Dr. O.P. Yadav, Dr. Isar, and Dr. Vijay Lakshmi. I think Kushagra. I'll request OP to start the proceeding of this session. OP.
Kushagra, the floor is to you.
Good afternoon, folks. I have about 15 minutes to speak to you about something that's very close to my heart, which is translational research in cardiac surgery. A lot of people don't understand what translational research really is, so I'll keep this as basic as I can and show you a lot of pictures and images to highlight to you where cardiac surgery has come in the last 50 years and where we think it's going to go, and why I think the opportunity in this country is probably the most fascinating of anywhere in the world. We start with the fact. Between 1901 and 1950, in the first 50 years of the last century, the Americans weren't considered the best intellectuals in medicine. But something happened in the next 50 years that caused it to change tremendously, and suddenly all the translational research in the world was being done over there. It wasn't by accident. It wasn't that the Americans became suddenly intellectually gifted and they were all now winning all the Nobel Prizes, etc. all over the world. But it was because the American universities after the Second World War was able to attract talent around tables that had many people from different facilities, different aptitudes, different areas, putting their heads together and coming up with what cardiac surgery in particular and many other specialties in general would be like 50 or 100 years hence. The NIH, which is the primary institution that regulates some of the research work done in the United States, itself hasn't been able to define translational research. Translational research really is the most nebulous, the most painstaking, and by far the most expensive part of research between innovation and application. You innovate in your mind, you take it to a laboratory, you try and develop an innovative application from that, you translate that application into something that can be actually used in a patient at the bedside, and eventually you get to clinical research. The most nebulous portion in the middle, as you can see, hasn't been well defined yet, even by sources that make most of the contribution to translational research in the world. There's only one component that's essential to translational research, and there are many of those in this country. Unfortunately, as of this time, India does not contribute to translational research pretty much in any specialty anywhere in the world. Obviously, there are many other areas than medicine where translational research has been much more progressive and much more rapid. This is one of the first computers, the Harvard IBM Mark I, which was actually stored 72 numbers, and you can see the size of that. You can see what's happened to computers ever since. This is the first Apple, this is my Apple today, and this is the chip that was released yesterday by Apple called the nano chip that goes into the new Apple V. Pretty fascinating how translational research has worked so quickly in other areas than heart surgery. But in heart surgery, the man who's been christened the father of modern surgery, an Austrian gentleman by the name of Dr. Christian Billroth, said just about 130 years ago that heart surgery was pretty foolish. You shouldn't be attempting it, because if you did attempt it, you were sure to kill a patient. We've moved quite a ways in the next 140 years, but this journey didn't start again right then and there. And it took a lot of different people with a lot of fortitude, a lot of different people who took a lot of risks to be able to create new beginnings in where heart surgery has gone today. So in the history of heart surgery, there were 3 problems to solve. The first problem was to stop the heart so you could actually operate upon it. Then to fix the problem that was actually brought the patient to the operating room, and most importantly, keep the patient alive throughout this issue. And obviously, stopping the heart and then restarting it was one of the most major problems faced by surgeons at that point in time. This is a picture of Walton Lillehei, one of the pioneers of cardiac surgery. This is an illustration of cross circulation, where babies were actually hooked up initially to their fathers because the fathers were thought to have a more masculine and more powerful heart, and eventually they recognized that the fathers weren't the best cross circulation donors, and this was then switched to mothers to be able to stop the baby's heart while the circulation was taken over by the mother's heart, and then proceed to fix congenital cardiac defects. Of course, you all have heard of Gibbon, John Gibbon. Orville Wright is one of the guys who flew off the cliffs in North Carolina, and Orville and Wilbur actually produced the first aircraft. He, along with IBM and Gibbon, were the people who produced the first heart-lung machine at the University of Minnesota in 1953. And look, in 50 years or 60 years, this hasn't changed very much. People say about cardiac surgery, if you fly to the moon, come back after a decade, cardiac surgeons would be doing the same thing that they were doing 10 years ago. We aren't dinosaurs, but we like to be very conservative. And that's where translational research is trying to change some of the problems that we don't see in heart surgery. You put a person on the heart-lung machine, the only problems you see are 10%. You don't see the other 90%. Like OP just talked about the fact, putting a clamp on the aorta leads to a huge amount of atheroemboli that are dissipated into the aorta, and this can cause stroke and other problems in the brain. And obviously the brain is a pretty important organ, and if you take an MRI picture before putting the patient on the heart-lung machine and another picture of the brain after the heart-lung machine, you can see the amount of edema that's seen in the brain after that. And this is a picture of an old vitreoretinal angiogram, and you can see small vessels cut off over here in the northeast corner of the angiogram showing microemboli that produce this. Obviously things changed. Things changed for a number of reasons, sometimes more out of necessity and other things, and sometimes out of pure passion to try and change things. Well, what changed cardiac surgery, and again OP alluded to this in his last conversation, was the reinvention or the readvent of off-pump coronary surgery and a simple invention which was then first started as a stabilizer, and this just stabilizes the heart, and here's a picture of what happens. A small area of the heart is stabilized while a surgeon then puts a graft onto the native vessel that's diseased. It's not a very difficult thing to do, but really that's how it's done. The amazing thing is the stabilizer is sold in the United States for $1,000. I have a picture of a dinner fork over here, and the reason for the dinner fork picture is simply, if I click on this and I break the 2 prongs of the dinner fork, wow, it becomes a stabilizer. So what is translational research about? Translational research is the fact that we can take a McDonald's fork that is given away for free, color it blue, white or whatever you want, and use it in the operating room for a stabilizer. And you don't have to use $1,000 stabilizers anymore. And that's the opportunity that we have in this country to be able to innovate like this and fast forward translational research. I'll jump fields very quickly and talk a little bit about cardiology. I bet most of the cardiologists in this room don't know about this gentleman. Werner Fosman was an intern at the Eberswald Hospital in southern Germany when he was very passionate about trying to do cardiac catheterization. If you don't know this, he was the first person to do open heart or cardiac catheterization, and he convinced his operating room nurse, telling her that she was going to do it on her, but when they went into the operating room, he actually attempted this upon himself successfully. Obviously, the hospital wasn't very happy about this and threw him out, and he became so disillusioned that he joined the Nazi party. Eventually, he went back to being a surgeon, and 30 years later, he was given the Nobel Prize for the first ever cardiac catheterization. Now, this is quite immense for a person to be so passionate about research and changing technology that he would use himself for experimentation and translational work. I don't have to tell you where cardiologists have gone today and the improvements that have been made in the technique that was first used 75 years ago, and what it's doing to help millions of patients all over the world. One other thing, this is a ballpoint pen that we have many of on this table, and this is the spring that goes into the front of the ballpoint pen. If you go to a ballpoint pen manufacturer, the spring costs 5 paisa. 5 paisa. These are drug-eluting stents. They don't look very different, but they cost $5,000. There's no reason for that to happen. This ballpoint pen spring can be made of nitinol or a nickel titanium compound, which most of these stents are now being made of. You take $2 worth of medicine and coat the spring with that, and lo and behold, you have a coronary stent. Something to think about. Another area of cardiac surgery where there's a lot of activity happening, aortic stenosis, which for many years we thought was our forte and nobody could take that away from us. Well, guess again. This is how aortic surgery was happening, and this is an open picture of an aorta looking down at the aortic valve. You see an aortic valve normally looks like this. When it becomes stenosed, it looks like this. These are a couple of different kinds of aortic valves. There's many different kinds. That's a metallic one and that's a bioprosthetic one that we use to fix aortic stenosis. Today, surgeons at my institutions at the University of Miami, to train in cardiac surgery, they have to spend 6 months in the cath lab and get adept at maneuvering catheters into the heart, just like cardiologists do in the interventional lab. And now we can put a wire followed by a stent, the stent containing an aortic valve, and through a small incision in the groin, if the femoral artery is big enough, or through a small incision in the chest if the femoral artery is not big enough, we can actually go ahead and place these aortic valves minimally invasively. And there's no doubt about the fact that 5 years from now, open aortic surgery is not going to be present anymore. Just like cholecystectomies being done openly are a thing of the past, aortic valves are not going to be replaced openly anymore, because this technique is extremely good at being able to do the same thing. Something that's close to my heart, because this is what I do for a living, is heart transplantation. Heart failure is a very, very bad problem everywhere in the world. Of course, in the US, it's the #1 DRG, or the diagnostic related group, for patients being admitted to hospital. Something changed about 9 years ago. When we were in medical school, we were taught that the heart has 2 pumping chambers, the left ventricle and the right ventricle. It took a Spanish anatomist, Francisco Torrent Guasp, who used to work on shark hearts, to actually unravel the muscle of the left and the right ventricle as a single fiber. So really the muscle of the left and the right ventricle, when you form the apical and the basal loops in embryology, is not 2 distinct muscles separated by an interventricular groove. It's actually one muscle, just like the double helical pattern of DNA being rolled upon itself. But imagine, it was not until 1995 that cardiac surgeons and heart failure physicists or physiologists actually figured this out. This led to an enormous amount of research in technology of what could actually replace this. This is a picture of a heart transplant being done over here. And of course, we know that heart transplants are kind of stabilized at about 2,000 in the United States. And there's a number of reasons for that. Surgeons as a lobby in the United States say no to helmets, because if you're wearing a helmet and you have a motorcycle crash, you don't die. And if you don't die, you don't become a donor for a heart. So we want more brain death so we can actually get more hearts for patients to be put into. And of course the same thing for a gun law. But there's a huge amount of research happening in other areas, which I'll talk just a little bit about, where heart transplants can be avoided. This is a picture of Michael DeBakey in April 1, 1966 at the Texas Methodist Hospital, implanting the first assist device, or the first extracorporeal pump. There are multiple historical devices. This is one of the first ones. This is part of the Smithsonian exhibit in Washington, D.C. This was what happened in 1990s. A VAD, or a ventricular assist device, used to cost $250,000. Most of them were placed outside the body. The later one, this is a HeartMate, that's a Novacore, they look very much alike. They were placed inside the body or intracorporeal. In the 2000s, we went to being from big to miniaturized. This is the DeBakey NASA VAD. This looks like a jet engine because instead of a propeller, it has an impeller. And that is the Jarvik 2000. You see, this is a matchstick, and you see how small this VAD really became. But this is what translational research in cardiac surgery, especially in heart failure, did. Well, we didn't stop at that. In 2010, or actually in 2007, when the first totally implantable heart was implanted, at that point in time, this first patient who had this AbioCor implantation done lived a total of 29 days. But that was one big step towards the future. Today, I'm only showing you 2, but there's a dozen different companies out there that make totally implantable hearts. The problem is, how do we power them? So now we work with electronic engineers in Stanford University to try and see if we can take batteries that can be charged transcutaneously instead of having a power line go through the skin to charge these hearts up. So how do you translate the ideal device? Obviously, do no harm first, and hopefully what you do is eventually good. And how do you know where to go? Well, I certainly don't, and this is a very famous footballer who I consider a very good philosopher, who ended up being where the ball was going to be at. Hopefully, many of us eventually are going to get there. Lessons? Medicine is anecdotal. Physics is what is fact. Mathematics is fact. We've got to be able to translate physics and mathematics into medicine and be able to guide industry where this can go. Obviously, there are numerous opportunities in the areas that I enumerated and many others in heart surgery, where translational research is going to carry on for a long time. In my opinion, this country is blessed with circumstantial opportunity today, unlike any other, and we can really beat the Americans at doing translational research, A, much quicker, B, much cheaper, and C, eventually have an impact that is significantly greater than whatever we actually plagiarize or copy from them that they do first. Obviously, perseverance is very, very important, and you see this frog trying to strangle what's eating it. And that's the whole idea. It is difficult to change status quo, but if you don't try, it'll never happen. Thank you very much for your patience.
Thank you very much, Dr. Kushal. That was a most fascinating lecture. In fact, I must admit that it was more fascinating than the Miami Beach sand. And give him a big hand.
Would you like to say something?
I think this is all the more important. He has said it all. For a country like India, we can't spend on poor research in the labs. And so much has already been done which has not been put to any application, and that's going all down the drain. So I think it's time that instead of having these big central institutes and central laboratories, we should now talk of application work, go out and reach out to the villages and to smaller centers rather than concentrate ourselves in opening these big centers. So wonderful, wonderful presentation, Kushagra. Really enjoyed it.
I think it's a very outstanding presentation. Insight of the technology. I think it was very, very beautiful. Yes, sir, you want to give some comment?
Truly amazing journey
Can you just switch on the mic, please?
truly amazing journey of cardiology and cardiac surgery. It's really fascinating how cardiac surgery is done. Patient is put on bypass while heart is not working, but rest all organs are working. It is really, really fascinating. I'm a cardiologist, but whenever we go to OT, we see that it is really fascinating, and many new things are developing in cardiology also. Like recently there were reports like robotic interventions. You sit outside, you don't have to wear lead aprons, and you don't have to be exposed to radiation, and you do intervention on robotics sitting outside of the lab. And there are recently reports of MRI interventions done under MRI. Right heart study was done recently, and there was no radiation exposure, and MRI helped in intervention. So there are new and newer things are developing.
I think, Vishal, it was a very...
it's very, very reassuring to the surgeons that cardiologists come to the theatre for fun. I always thought they come to the theatres to take over from us. So, thanks for telling us that.
I think it was a very lucid presentation, very informative, and a time has come. There has to be paradigm shift. And transformational technologies have a tremendous role, and I really wish Kushagra best of luck, and I'm sure something you will do by some kind of innovation in this field. Let's give a big hand to Kushagra.
And hope he'll translate his ideas into action in India.
Ladies and gentlemen, I would like to thank the chairpersons of this oration.